good evening, everybody, and welcome to our series of webinars on education about digital health and telemedicine and uh, the ecosystem of telemedicine in general. And so, in that series, we would like to, today move with. Let me just 1 second. We'll go to the session today, and I'm waiting for the next speaker to join. But in the meanwhile, let me give you an introduction of the panelists today. So we have two eminent panelists. One is Mr. Vijay Simha, and second is Mr. Gopi Gopalakrishnan. Whereas both of them have started from technology background, but have charted different courses, and I think it is. I must tell everybody that both of them started their journey in BITS Pilani, and have now they do a large part of their work in areas which overlap each other as well. So to introduce Mr. Vijay Simha, he's been in product development, engineering, manufacturing, and almost all the spaces related to products in the health tech space for the last 30 years. And he has a very wide ranging international experience and exposure, and has dealt with many problems in the healthcare space. And at the moment sits as on the advisory of FICCI for Lemelson Foundation, BIRAC, uh, Indra, Zilico. I mean, there are many companies. And for the uh, session today, he will be sharing with all the innovators and entrepreneurs today as to what are the difficulties that they're likely to face. How is it that the devices that need to be worked in the telemedicine ecosystem? And he'll be sharing his experience and also will be addressing questions that you might have. Whereas Mr. Gopi has probably one of the largest uh, telemedicine services that are present in the country today. He's with the organization he's founded, that is World Health Partners, and works primarily with the primary healthcare, rural health communities, and has a large number of patients on his system. I think they've been in this telemedicine space for more than 20 years. And it would be interesting to see how the journey has been for him and his company, and what are the challenges that they foresee, and how is it that they have forged partnerships with various device manufacturers to really provide a more robust telemedicine service to the clients, the patients, as well as the healthcare providers. So I'm going to invite Vijay now to address you. So Vijay, over to you.
Hi, yes, it is on unmute. Um, Good evening, and I look forward to this very healthy interaction, and I do look forward to a healthy debate, as I mentioned in some of my um social media posts. Um, the whole concept of telemedicine has been around for maybe over 20 years, which is 2 decades. And a lot of people have been talking about telemedicine as a panacea for the creating universal health access, universal health coverage through accessibility, which is trying to reach the last mile using telemedicine. Um, and a lot of companies have been talking about bringing in new products that can actually fit into this space. But what was the mainstay at that time was the concurrent development of a central nursing station, which was used in an ICU. Um, this central nursing station was connected to the ICU equipment through a series of networks internally in the hospital, which kind of translated into getting put onto a series of internet-based or telecommunication-based networks to be able to connect people um, from a long distance. When I say people, it meant the patients and the doctors. So this was a one-to-one conferencing solution, and a little bit of devices on the other end to be able to check temperature, blood pressure, maybe an ECG, some heart sounds, and this became the mainstay of a physician in a remote area trying to conduct a physical examination on a patient, confirming that his vital signs were in order, and if not, then that would give a clue on how he would be able to sit and diagnose diseases. But that was probably not enough, because obviously a physician needs more information about the patient in terms of the various sort of physical and diagnostic information before he arrives at his conclusion on what could be the best way to treat the patient. So uh, this this was the initial concept, but it was mainly on paper, and a lot of discussions on it, just because of the fact that we were talking of universal coverage and universal healthcare for all and that sort of thing. But at some point or the other, a few people began to, take uh, the fact that they would like to try this out in the field, and a number of pilots were started out. I can remember a very simple one, where in a company called BPL Limited, um, they were pioneers in Indian ECG machines. They made Indian ECG machines, and one way they thought that this would could be implemented in terms of reading an ECG, because the local people were not competent enough to be able to read an ECG. They bundled a fax machine along with an ECG to be able to send ECGs to, say, a cardiologist in a hospital. I think this was in Tamil Nadu, so it was between Vellore and other districts of surrounding Vellore. And it had some of its high points, in the sense that there was a person who apparently had all the symptoms of an AMI, and he was examined in a small clinic in Tamil Nadu, and his ECG was sent over, and so therefore the story ends with the fact that this gentleman, who was a VIP in that area, he was probably an MLA or a politician in that area, was saved by this modality. And we hear a lot of stories where uh, the whole tele ECG concept came up with Narayana Hridayalaya setting up a number of centers across Karnataka, Andhra Pradesh, and if a person came in with all the symptoms, and the local um, people wanted to examine the patient with the help of a cardiologist, they would be able to do it at that time. So as time passed, of course, this organization, which if Gopi hasn't joined in, but this organization which Gopi has been associated with and started, called the World Health Partners, actually implemented this on a fairly large scale. And I would like him to actually, sort of describe his learnings. But they had a lot of challenges in front of them. One was possibly, Gopi, I can see you've joined in. So um, I will just, sort of segue into your uh, experiences and learnings. And the intent here is that they have actually scaled up this effort more than anybody else can actually scale up, which of course Gopi will mention how he actually was able to cover parts of Bihar and UP, which were completely away from any kind of coverable, you can say, healthcare coverage, and then also made it a community sort of an activity, where the local people as well as the local folks out there took ownership in ensuring that this whole activity would also become a part of their sustainable growth program in healthcare. But then, of course, there has been many sort of learnings that have happened from there, and the world has moved on, and so has World Health Partners. And then, of course, Gopi continues to sort of bring in the newer aspects of how the changing environment, the new technologies, and also the new environment where telemedicine now has become actually a legitimate thing. And today you have a whole rush of people coming in talking about universal healthcare again. And I'm sure in this universal health coverage, telemedicine will continue to maintain its predominant uh, lifeline kind of a backbone. And yeah, so I guess that there have been a lot of operational issues. There have been human factors issues, and then of course there have been process issues, which we could sort of briefly cover. And I'm sure Gopi is just waiting in the background there to cover. So, Gopi, hi, and good to see you again. And would like you to come and sort of give us some gyan on the stuff that you've been through.
Yeah, indeed, it's going to be. Thanks for. There are some connection issue, so I had to keep going back. It's nice. It's all worked out. Um, Thank you for the introduction. Wait. See, the way we started was because earlier I was associated with an organization which did things in a manual way, in the analog way, delivery of care to communities. And when the major problem we had, of course, was doctors did not want to go and live in rural areas, and understandably so, because even if the doctor is from a village, by the time the doctor has gone through medical school, he or she has become an urban animal, and it's not really fair to expect them to go back and live in an area where the kind of creature comforts they got used to in urban areas were not available. So accept that reality, and then how do you build it? And when we started, the connectivity was extremely low. We had 2G and 3G kind of connectivity, and that's where we started. But now is the situation, and we had therefore, Vijay referred to a lot of difficulties we had. Most of the difficulties were to do with not so much with the application that had any problems with it, but the pipe through which this application was carried to those interior areas. Especially because the state I'm talking about is Bihar. Bihar is the area where I've had the most experience. I lived there for 10 years, implementing healthcare programs and reproductive health programs. So that's a state I'm most familiar with. And that state also had the least level of telecom development. If you look at the country as a whole, now the situation has changed dramatically. You get much better connectivity in Bihar than in, say, Delhi. Delhi, most of can you guys hear me?
Yeah,
Yes.
Yes,
we
sir.
can hear.
Yes, sir.
We
Yes.
can.
Okay. Because there is some noise that came in between.
That helps, yeah.
Yeah. So that's what it is. So what I will do is uh, from the experience we have had so far. Okay, the Bihar, the project got pretty interesting when the Gates Foundation heard about us and visited us, and then wanted us. They wrote us a nice big check that implemented on a large scale. So we did across 13 districts. So 13 districts in Bihar would almost be about 70 million population. Those districts had about 65 million population. Almost like a country in other parts of the world. And the whole idea is, and when we say 70 million population, it is to cover extensively. It's not like you work in an area in one corner of the project area and claim credit for serving the needs of much larger. Hello. Okay.
Yeah. Once
So,
in a while, I
so
think.
with this, we started. We developed the solution and deployed it. Rural entrepreneurs, and right from the beginning, it was also very clear. Even though there was a grant available from the foundation, right from the beginning, we wanted to create an ownership of the other constituents in the program. Otherwise, what will happen? You give everything away free, and maintenance, especially when it is technology related investments. Maintenance would be terrible. No one would bother about it, etc. So right from the beginning, we made sure that there are entrepreneurs in rural areas who would invest their own money to join the network, and we will provide the back-end support. Um, and that's exactly how it happened. Initially, we thought we would use the best of the village as the entrepreneur because there are a lot of educated people who had gone back to village for a variety of personal reasons and were available. Most of them women, a lot of women who were married into families in the villages, etc. But that was a complete disaster. This is before Bihar. This became a non-starter because most of such people, educated people, came from very well-to-do families, relatively speaking. They were from the best because they were the most educated. And they really didn't have a connect with the rest of the community. The community did not see them as someone who could provide or care for them in a way which is required for healthcare delivery. So we scrapped that plan after trying it and and we were using VSAT terminals, etc., to connect with those people, with those communities, because we were working really, we were working in interior parts of um, UP at that time when we started. So in Bihar, we were doing rural entrepreneurs who were normally from the healthcare sector, who were all entrepreneurs who were providing healthcare, the so-called quacks. And those guys made the investment. Our plan was the quacks would already had this traffic coming to their centers, and therefore they would be able to connect with doctors. And the community would also be able to access city-based doctors from those areas. To cut a long story short, that also has not worked all that well for the simple reason the quacks are able to handle telemedicine per se is at this stage is handling care at a primary health level. You're not going for any sophisticated treatment. At best you can screen for cases which require which require condition at high level, secondary and tertiary level. But by and large telemedicine has been tailored for primary health care. Ironically, in India, the market is so badly regulated. The rural healthcare provider, the so-called quack with very suspect degrees, is able to access any medicine. In fact, they are able to access medicine better than even a city-based doctor, and is able to treat any patient. And that is the competition to telemedicine, ironically. So if it is a small illness, the community doesn't feel it is worth getting in touch with the doctor and incur a higher expense when the local guy can treat you as well. In fact, the local guy can treat, from their point of view, the local guy can treat them better because if there is, say, a farmer who is feeling very tired and exhausted for whatever reason, we would probably give him, we will follow a protocol because ours is entirely protocolized. And we would do the treatment according to whatever medical protocols allow us. Whereas a rural provider will have no hesitation prescribing steroids, for instance, to the farmer, who will feel invigorated, go back to his field, plow his field, and offer to plow the field of the neighbor also because he feels stronger. But the only thing is, it will come back and catch up with him later on in life. And we, as an organization, cannot do that. We cannot take those risks. We cannot be so casual about medication. So this is the competition. In So this is what we are now doing. We have just entered into that phase where we recognize that there's absolutely no point in handling very simple illnesses even though that is the most 80% of your illnesses. That's what your quote unquote market is. So if you want to be sustainable without dependence on external donors like the Gates Foundation, there are only two, and we are also, as an organization, we are not interested in small marquee or boutique projects. We are interested in scale. How do you, so far, our programs have handled about 28 million cases. So that is the scale at which we want to operate. And there are only two options available. And when it comes to scale, your problem really is not your investment, initial investment or initial device. Your problem is entirely is your ability to meet your recurring costs. Once the network is created, how are you going to meet the service delivery cost, the recurring cost? And there are only two options available, which will allow you to operate at scale and also meet the recurring cost. One is the private sector. If you can tailor your solution in a way so that the community will pay a sum of money which will enable you to break even, because we are a non-profit organization, so we don't have to make a profit, which will enable you to break even. That is fantastic. In fact, that is the best way. If you can do that, nothing like that. As I explained to you earlier, it is not so simple because you have competition from the informal sector. So currently, what we are doing is we have developed the algorithms, and the initial algorithms were developed because of the Gates Foundation involvement. We had access to some of the best medical skills of the world. So people from Stanford and UC Berkeley, in India, a number of prestigious institutions, and Stony Brook, all of them were involved in developing the algorithms, which we used for simple illnesses. Using the same pattern, now we are developing the algorithms for the next level, cases that the rural provider will not be able to handle, which he or she would have normally referred to a physician at a city. We are now, in fact, we have made the algorithms and we are just fine tuning them so that there is an opportunity and a case we can make for the rural provider to refer cases. They themselves become the conduit to the higher level of care. Plus, we are deeply involved in TB care, and there is a government provision available for TB cases. So they can earn some money from us instead of client paying. They can make money from our program, which the government provides. And how do you take it forward? The second place where we are strengthening our telemedicine solutions is with the public sector, because in the long term, if your organization is interested in reaching to the poorest and the most vulnerable communities, if the private sector is possible, nothing like it, but often what the private sector requires by way of payment is beyond the reach of a lot of very poor people. And the only choice, therefore, is to get the help from the government, which is not easy, which is a nightmare. I realize that, but we still have to do it because the governments will never run out of money. Whether it is Gates Foundation or Packard Foundation or any of them, after a point, they will say how much longer, because the recurring costs they cannot meet forever. Initial costs they are willing to bear, but the recurring costs we'll have to figure out a way of bearing. So to repeat the story, either you get it from the private sector where the client is willing to pay that amount, therefore you can break even. And if you're a company, therefore you can make a profit. The only other choice where you have to reach to the very poor who cannot afford to get the services from the private source is to go to the government, is to partner with the government. And that's what we are doing increasingly. During the COVID outbreak, we repurposed our solution and deployed them across Andhra Pradesh and Bihar. In Andhra Pradesh, it even got a political support. The chief minister took an active interest, and it is called YSR Telemedicine. And that was done across the state, where the approach was not on COVID, approach was on what are called OPD cases, your kind of ambulatory cases, and within which the doctors identify patients who could be COVID suspect. And for the general OPD, the government made arrangements for delivering medicines free. So the doctors could connect from their own homes because they were all locked up at home, and assisted by personnel who were also locked up at home, but providing care to patients who are calling from any part of Andhra Pradesh. In Bihar, there was no medicine because Bihar, in the best of times, has trouble supplying medicine. So it was just a consultation, and the patient will get a regular prescription, and this prescription will be filled by a private pharmacy who, even during the peak COVID outbreak, were allowed to operate. So these two are continuing. So we are doing the private sector where it is an enhanced service, not just traditional the first level primary healthcare, because that has huge competition and we don't have a chance of making any headway there. Second is lock in with the with the public sector and fulfill the need there. Once COVID is over, it will transition to general healthcare. Governments are increasingly tendering out this responsibility to outside parties, and that's where we participate. I'll stop there because I've spoken. I hope I've given an overview. I can then respond to any specific question.
Sorry, I need to ask. I hope this session is being recorded and it will be available.
It
These
is
are
being
golden
recorded.
words.
Yeah, it is being recorded, and these
And
are available. Yeah, these are
okay,
made available
okay,
after editing a little. We make it available.
okay.
Vijay, do you
Thank you.
want to take it from here and add any comments that you have?
Yeah, I mean, I've been sort of, I would say, in the proximity of Gopi in many of his, trials and tribulations, though not necessarily involved very deeply in the activity, but have been a very, very enthusiastic student in the study of this particular modality on the work that he's been doing. Um, I would say the intent here was more educational to a lot of people apart from the guys who actually developed this whole modality, and the awareness that the healthcare system has to be created amongst the public is probably one of the most predominant exercises. Like, for example, Gopi mentioned between the local practitioner who is maybe not necessarily a qualified person, but is an experienced person in handling a few symptoms and taking care of those symptoms so that that person
Yeah,
is able to carry on his work, versus another person, the real doctor, who is of course governed by a number of sort of processes and protocols, and then of course the continuum of care possibly after that. If you look at all this, um, the the whole modality was that, okay, there is a crisis, we need to solve it with a few medications and and do symptomatic relief at the first round itself, and then maybe move to a paradigm where we look at a continuum of care much later. So this was in a world where you had a lot of acute problems, and communicable diseases or infectious diseases were ruling at that time. um, the NCD part of it was really not the focus area at that time. It was basically a lot of diarrhea cases and flus and fevers, and we have a number of infectious diseases, and they have not gone away. I mean, that's what we are seeing even today. Uh, we must have thought. I remember there was a discussion in some of the major meetings at the in the DST, where we would try to say, like, what would be the future requirements of healthcare in this country. And when cardiovascular disease was mentioned, they said, well, I think that's the disease of the rich. And we were all kind of a little stunned because we knew what it was like in terms of its impact on the ground. So there was this disconnect, and the whole intent now was to move some of the activity into some of these non-communicable diseases, and at the same time they were chronic, and so therefore they had to have uh, a, a method by which there was a slightly longer term than just prescribing a tablet to give symptomatic relief for the moment. And this was actually seen in some of the developments. And simultaneously, while this was going on with Gopi and his Bihar experiment, there was another initiative which was started by the Satyam folks in Andhra Pradesh. Started with 108, which was the ambulance services or the emergency or pre-hospital services, and then moved very quickly to start up something in the primary healthcare activity, which was founded on a very similar kind of a mobility solution using uh, vans or clinics on wheels, and these clinics would visit various centers on a weekly basis, and they would have equipment which could conduct some basic diagnostic tests, and had a couple of doctors on board and nurses on board, and small procedures like suturing or whatever it could be carried out. So um, this was picking out pretty well, and I was associated with a couple of those installations there as a person who was also sort of looking at my equipment to serve in that kind of sort of area. And they managed to scale up to a certain extent, which was quite impressive. They had also a number of I mean, the number of patients whom they have impacted, and were building up a fairly large, sort of database on patients and what they were doing. Uh, and this was spearheaded by uh, the chief minister of that time, by Mr. YSR Reddy, I guess. YSR, we used to call him. And when he died in a helicopter accident, I think the whole program also went for a crash, because politically, I think he was not in favor with the following governments, the successive governments. And I don't know. I mean, now I don't hear about it, but I know that a lot of people who were involved with it were so passionate about the way this was going to work. And in fact, in one of those I would say installations, we were involved in places which were, very thickly infested by Naxalites and that sort of a thing. And the Naxalites also were very concerned that what was this stuff coming up here with cameras and that kind of stuff. And when they knew, and it was explained to them that this was basically a telemedicine system, I think uh, they were very kind to the rest of us for even attempting that. So this was some of the stuff that have been happening, and today now we have major challenges which we actually see have been part of the learnings that have happened in the past. One is um, the equipment that was there was based, as Gopi mentioned, on very narrow bandwidth sort of connectivity, and this narrow bandwidth left a lot to be desired in terms of the kind of interaction one could have, because between a physician and a doctor, there are a lot of visual cues, there are a lot of uh, examination processes which a doctor would require or a physician would require before he is able to understand the cause of the disease, and also what is the extent at which the disease has progressed. This is important for him to make a clinical decision on what is the best, sort of approach that he would have. And this required more and more sophisticated systems. Now, uh, today we know that we have really very good diagnostics. Unfortunately, many of these diagnostics fall in the area of requiring either sophisticated equipment like fluorescence spectrometers or luminometers and stuff like that. Plus, in addition to that, they need, like the vaccine, they need good cold chain control to ensure that the molecular diagnostics are still active as they reach these areas so that the diagnostic results would be good. This is, in fact, a very, very is a very important part of the whole network uh, or infrastructure that needs to be built. And COVID was a good reminder or a stand-up call saying that, okay, let's not take it for granted. One thing, it's agnostic to the kind of people it can infect, whether you're rich, poor, whatever it is. And the second part of it is that um, it could spread to areas where you probably suddenly find that you cannot uh, ship out a vaccine, say, for example, uh, the minus 60 degrees or whatever vaccine that you need to ship out, you need to build the infrastructure. And that brings it back to, you know, point one, the operationalizing of a telemedicine outfit, even whether it is just purely diagnosis or whether it is going to go into area of immunizing populations across large areas. And most of them, obviously, you know, in India, they live in villages which don't have that kind of infrastructure to be able to, you know, support this. So that is one. The second part of it was awareness, the need for creating awareness within the community that this is good for you, this is helpful. Do not ignore a situation. I mean, every day there is stories that are coming in, which tell you that if the person was aware of, you know, some basics, it would have saved their life. And this is something that uh, is very, very top of our mind, in the sense that you have a diarrhea and 2 days later you're dead. What were the decisions that could have been made to have been able to save that person? So that was another aspect that we've been discussing. How do we empower people in being able to do that? And that's a long road. And I guess telemedicine is one conduit in which much of this information and awareness can reach people. So this is some of my two bits that I would like the audience also to be able to mull over, and and then take these as learnings, which probably could uh, make a better and more productive and clinically viable process to be able to lead to a better telemedicine outfit. And this is one of the reasons why we've also looked at devices. And we know that devices play a vital role in being able to provide correct information and timely information. And at the same time, these devices have to give the right kind of information to ensure that the doctor makes the right kind of decision when he is prescribing medication. And one of the efforts that this organization called Digital Health India is attempting is to be able to build that kind of a registry where people can validate those products and say, yes, these are the things that it can be used for, but you need to take care of these things in this way to be able to get maximum out of it. And at the same time, these are the areas where this device will not solve a problem, right? So um, I would stop there and hand it over back to Dr. Uma.
Yeah, thank you, Vijay, and thank you, Gopi. Uh, it's been a good start. Uh, it's an excellent start to the day. And as I have mentioned to everybody who's participating here, that the amount of experience you to bring from the ground is enormous. And Gopi, would you like to address this question that Manoj has asked about the ecosystem piece? Because there is telemedicine solution, and then there are these devices that connect so that the usability of telemedicine gets enhanced, and then you have this entire ecosystem where the complete assessment and diagnosis of the patient can be made, and there could even be devices that can later help in intervention, and it can help build a very robust system on which the rest of the in physical, the face to face care can happen. So will you elaborate a little on the ecosystem so that we can then take the other questions? which are related?
Sure. This, in fact, gets to be the most crucial part. So let me kind of frame it at a slightly higher level. Fundamentally, healthcare, at least that's what we believe, and that's what we try to execute. The best health delivery system is when an illness is prevented, or a simple illness is prevented from getting serious, which means either you immunize people where you can provide them the preventive care, and also ensure that there is a triaging system that is set up by which the lower level provider either provides the care or takes the responsibility to refer the case to the higher level, to the appropriate higher level. Sounds very simple, but this is not what is happening, because 80% of the cases that are turning up at your secondary and tertiary facilities have no business to be there. They should have been handled at the primary health level. Okay, but we don't do that. So telemedicine is to that extent, we'll have to define it in that context. And this is exactly for those who are academically inclined. There was a conference in 1978 in a place called Alma Ata, which is now called Almaty. It's called the Alma Ata Declaration. It's a very famous declaration, which mentioned that which brought primary health to be the core of any healthcare delivery. But the primary health has two parts. One is the preventive part, like immunization, antenatal care, even family planning, which are all preventive in nature. And the second one is primary health also has very low level curative care, and the curative care part was phased out because during those days in the early 80s, etc., no government in a developing country could find healthcare providers, medical providers at that level. So curative care was phased out. And almost all programs in the world at the bottommost level focused on preventive care. So you will find in the sub-centers, for instance, the A&Ms give, they immunize, monitor the growth of children, pregnant women, how the fetus are growing, but they don't do any curative care. Telemedicine has come and changed the game. Okay, we can now have the same level of provider, and a nurse midwife at the village level, who facilitates a care and connects with the doctor so that this can be handled by the city doctor. And the city doctor finds that this cannot be handled because the case is too complicated, then it can be that doctor takes the responsibility to refer it to the higher level. So that is one way. So there is going to be a digital backbone that will go across primary to secondary to tertiary, and all of them as one unit. Either the basic principle of triaging is that either you handle it yourself or you take the responsibility to refer it to the higher level. It's not the patient who will decide I've got fever and therefore let me go to the and get it treated. The doctor can treat it easily, but that's a very expensive way of treating a fever by a specialist doctor. So how do you prevent that from happening? The ecosystem part comes when you also have into pharmacy, for instance. When a doctor writes a prescription, you'll have to make sure that the appropriate medicines or that are prescribed are available. Some investigations can be done. So all that is integrated into an ecosystem. And even more important in the public sector is the administrative function, because in a state like Bihar, the level of absenteeism is anything up to 70-75%. Okay. Even during the COVID outbreak, when we were doing it, the government doctors were the ones who were providing the care. There were supposed to be 40 doctors on duty at every shift. Barely 3 or 4 would log in. And even when they did log in, they would just log out in about 10 minutes, because that is the stuff they are used to. They will go to a PHC, sign up the register and go home and run their own private clinic. Then the government had to issue instructions. In fact, they issued a warning letter to those people saying, you will have to join. Telemedicine gives you an opportunity to monitor it. You can monitor at what time the doctors come for duty, what time they leave, what do they do, what is the quality of interaction, all that can happen. So telemedicine is not just a city doctor providing the care. It can even be It can even be a face-to-face interaction in which the doctor uses some assistive tools, can use algorithms and diagnostics and protocols to provide care, and everything is controlled. So even at a tertiary hospital, it can be telemedicine where there is face-to-face interaction. So let's not narrow it down to anything, narrow it down to just a consultation that happens over the wire. It has to go far beyond that. And how do you conceive it as an integrated system? My last word on that is this. This is the major problem currently in India, because we don't have a blueprint. And the whole thing initially was driven by WHO, and we have been having running battle with WHO, because WHO, everything is run by specialists. There'll be a TB specialist, there's an HIV specialist, everyone would develop his or her own vertical. And now the entire telemedicine conference that takes place across the world, 90% of the time is spent on interoperability. You know, how do you get one kind of silo to talk to us? That is as crazy as it can get. It's like building a very big house and telling the electrician, you go and do your work, and the sewage guy go and do your work. And after everything is done, you try to figure out everything is properly done. No, you don't do that. You first have a blueprint. You know, you decide where the electric line will run, where the sewage lines will run, where the water lines will run, and then you build. That's exactly what will have to happen. And here is a historical opportunity for us to have that master plan, the blueprint, on which you print. You cannot do this post facto. After you have established everything, you will see it is, how do you make it interoperable? It will never become interoperable if you build it this way. It has to be conceived and executed one way. One crucial lesson, sorry, Uma, I'm taking too much time, but one crucial lesson for us is that initially our attempt was to build all the devices, you know, all the diagnostic devices, even as simple as your blood pressure machine or your hemoglobinometer, all those things from scratch. After learning the hard way, we just gave it up. Our entire system now has been tailored to take these devices available in the market off the shelf. You know, some of the best companies of the world, Omron or Philips or Samsung, etc. They make these machines and constantly update them. We will have to therefore have a platform into which all those machines can plug and play. If you want, you can get the API from those companies, which becomes very expensive. That is the easy way, but it's an expensive way. Our solution is to get those you know, kind of results, the readings from those, and get the frontline provider to enter that data. Because public sector feels extremely uncomfortable working with systems on which they create their own dependence. You know, after this is very addictive, and the public sector doesn't want to take that risk. So make sure that you don't invest your time developing devices already available in the marketplace. Instead, you try to focus on solutions which will integrate those devices well into the marketplace. Okay. And this is the only way you can engage with the public sector. Otherwise, it's going to be a problem. Yeah, I'll stop there.
Unless it becomes cheaper to work with a device company and this API sharing comes at a lesser cost, and perhaps government intervenes and helps the providers, there could be some solutions around.
Yeah, if you can do that.
The
point, I'll give you an example from Bhutan. Bhutan used a Singapore company which came and digitized their entire, you know, at the tertiary and secondary level, the entire tertiary, secondary facilities. And after 3 years, the Singapore company increased the price 5 times, because the system has got so dependent on what the Singapore company offered. After 3 years, the company realized that it's going to be enormously difficult for the government to phase out and do something, especially when something which is like healthcare delivery that is very time sensitive. And so those are the ones the government is wary of. So you'll have to be careful. Whereas if it is available off the shelf, you don't have the danger. If Philips price has gone up, then you can go and buy it from someone else and you just get the reading. Plus your ability to upgrade, because that is not your primary competence. You're not sitting and working on it. Whereas for Philips, that is a primary competence. The unit in Philips, that engineering unit, is constantly doing research to improve their devices. So that benefit will be available. So these are the concerns you will have to keep in mind while designing your model.
There's a very interesting comment here by Mr. Vamshi, who has written, you can see that most medical cases in remote places in India require only a GP to diagnose the common illness problems, and telemedicine might actually be able to help this. So it's actually not only in remote areas. I think it's across all towns. That is a problem. And I just want to, share my view, and I want to invite your comment on it. I feel that if you really build a very good ecosystem of telemedicine, it will actually fill the gap of the GP, which is clearly missing in India. Which is slowly, in fact, whatever was there has also gone out of the window because of this narrow super specialization and subspecialization focus. So, will this not work as a good GP focus if all the entrepreneurs who are in the telemedicine space work with that in mind? Do you think that's a good idea to think of, or do you
You
think that is what it is?
uh, in fact, the solution to making GP the center of the central figure in this configuration is is um, is administrative. If you can regulate the drug market, the medicine market, and cut the informal provider is your, as I said earlier, informal provider has access to all the medicines because it's a completely unregulated market. With GST, fortunately, all the medicines are made in the organized sector, which means there is a GST trail available right till the retailer level. Okay, if you can if you can loop in the doctor's prescription, a formally qualified and a registered, electronically registered doctor, only who can write the prescription, and the pharmacy will issue against that prescription. Then you can cut off the oxygen to the informal provider, and then there will be a huge market that is created, where the patient will be able to get medicine only if the patient comes to formally qualified provider. If you don't do that, for what Mr. Vamsi Krishna is pointing out, for simple illnesses, if you want the formally qualified provider, the city-based provider, to provide the care through telemedicine, that is always going to be much more expensive than the local provider providing the care, because that guy makes some pudia out of something. He gets samples from somewhere, from the doctors. He uses reject. All kinds of nonsense can happen. People in the south, I have a feeling a lot of your people are connecting from the south. They probably are not able to relate to the problem that we face in the north. The northern and central India, rural healthcare is almost entirely dependent on the informal providers. Whereas in the south, the transportation facilities are better, plus the penetration of is much higher because of the number of medical colleges which has churned out these doctors in the south. Whereas in the north, you don't get an MBBS doctor beyond a block level. So in that kind of a situation, there's an estimated 3 to 5 million. Numbers are not easy to come by. 3 to 5 million informal providers in the country, almost all of them operating in the northern and the central parts of India, who are the mainstay, and they are the ones who have access to that is available in the market. And if that link is not broken, your MBBS doctor will not have much of a say for these illnesses Mr. Vamsi Krishna is talking about. Because telemedicine, vis-a-vis the rural informal provider, telemedicine will be more expensive and people will not pay that amount.
Yeah, but can this telemedicine, when we are using telemedicine, can we use this informal sector effectively is what the question is. Because if we try to remove that informal sector, which actually in the northern parts, as you said, is in India, and especially UP, Bihar, MP, I think this is a huge, even in Haryana, this is a huge set of people but these are the only guys available in the village and the villager trusts them. So can we
Is it-
use the telemedicine ecosystem to empower them with more knowledge and with more access to knowledgeable guidelines for them, so that they can provide better care and they can be the conduits to take this better care to the
To
people?
couple of dimensions to that question. It's an excellent question, and a couple of dimensions to it. One is that the Supreme Court is totally against informal providers involved in any kind of provision of medical care. Health is fine, but medical care. We try to use the informal providers because when it comes to one thing that we need to understand in client behavior, consumer behavior, is that let's take that a very poor rural family, someone in the family is dying. That family will raise resources by selling a little piece of land or a buffalo they have and travel 1,000 miles to Mumbai or to Delhi to save that life. But when it comes to primary health care, lower end care, or preventive care, the same, even though the family has expressed an interest in getting that care, including for things like family planning, what we call unmet need in family planning, which is one of the most difficult areas to work in. That family will not spend too much money, will not travel long distances, and would expect the service to be available quite outside the doorstep at a price point which is very, very low. This is let's recognize this and understand this is the consumer mindset. You'll have to tailor your program to meet with that. So your rural provider therefore becomes very, very useful in that case. If you can use the social skills of the rural providers and combine with the technical skills of a city-based doctor for providing curative care, then there is a case to be made. That's exactly what we're trying to do.
Vijay, there's a question that probably, it's more for you,
My
and
stream.
it is from Avinash, and he wants to know whether, Avinash, do you want to unmute yourself and ask yourself? Maybe that's a better
Thank
way.
you, ma'am.
Yeah, go ahead.
Sir, are there CROs in public health system where trial for a device can be low cost? Because corporate CROs cost a lot, and I believe there may possibility in medical colleges or somewhere.
Right.
And how to approach them, sir?
Yeah. So, basically, CROs, of course, their job is to do clinical research, and some of them have competencies in doing for, say, devices. I know from where you're coming, Avinash. The fact is that in public health, there are organizations within the Ministry of Health, ambit of the Ministry of Health, to be able to evaluate a product to see if of its suitability, not only from the clinical and technical aspects, also from the operating as well as from the economic aspects also, because some devices may come cheap as a capital equipment, but the consumables they use, like Gopi was mentioning, could be extremely expensive. Or you become a captive audience, then you can start asking a price. So there is an organization within the Ministry of Health. Of course, there are two organizations which I know, and I think they're also kind of like the border is very, very blurred. But there's an organization called NHSRC, the National Health Resource Center for the Ministry of Health, which examines all these kind of devices, especially devices that are ready to be going on to the market, and then does a, a study on them and recommends a few, since many of these health related issues and purchasing of devices is a state affair. They recommend conducting this set of pilots in a number of states. So the local secretary, the principal secretary of health, along with his team, with the NHM director, would conduct a set of pilots and present a report which will say about the suitability of the product. Um, a very good idea and extremely useful. It's modeled on a concept called NICE from the NHS in the UK, where NICE also sort of looks at these resources. But unfortunately, I think the the group has not really been able to, come out with much of activity, except they have a portal where you can go and register your device and say that, it can be used for this purposes in public health. Um, can I can I be a part of it? So that's one of the areas where you can generate evidence on in terms of what they would say health impact analysis of your device, right? So this is one part of it. The other part of it, of course, is the device needs to be validated and tested for its basic functionality using the standard requirements for, say, a regulatory clearance from the Drug Controller's Office, which is the CDSCO, as well as the, say, if you're doing it globally, you could have an ISO 497, or you can say a C mark in short. So these are the various channels, but yes, the government intends to have a facility where you can analyze, I mean, you can conduct some trials, but I'm not too sure whether they have been able to get, the trials off the ground as they would like to have it as quickly as possible. It may probably be queued up and you're waiting for your turn to come in, which may be a frustration for you. Did that answer your question, Avinash?
Yes, sir. Thanks a lot.
Yeah.
So Shailaja wants to know how ready is the government to invest on portable and connected devices which are required to provide telemedicine in the public healthcare system. You
Um,
guys have any experience
you
with that?
you want me to answer it, Dr. Omar? I'll just give a background. The government uh, is keen on investing into a lot of technologies which will bring a little bit of, I would say, self-reliance within the company, the Atma Nirbhar Bharat concept, where um, healthcare has been identified as a strategic area where self sufficiency is one of the things. And at the onset of the COVID crisis, it has become more apparent. Simultaneously, we had this little tension that happened between India and China, and there was a point where we realized that we were dependent on China for a lot of medical equipment. Almost 80% of the oxygen concentrators and stuff like that were coming in from China, and people found it really difficult to manage without that. And then there was this move, and in fact, the government has come up with lots of initiatives to tell uh, entrepreneurs in India, saying that why don't you get into this business? We'll give you money to start it up. We'll give you the support, and then from there you can take on. So there's also an assurance of like if you're successful, we could even give you markets. We could even give you entry into the government businesses. So the government, with both its ability to fund startup companies who are intending to build products in India, and do some import substitution also, not necessarily purely innovative stuff, but even import substitution. In addition to the fact that they will provide a segue into a kind of preferential purchasing thing for Indian companies, uh, there is a lot of incentives happening. So if you're looking at it, BIRAC is there, heavily investing into med devices. DST is there. ICMR, through the Department of Health Research, provides sort of funding for conducting clinical studies and clinical trials. And um, you have other agencies that come in from there, like the Indo-US Science and Technology Endowment Fund, um, the Grand Challenges Canada, Bill and Melinda Gates Foundation. They are all ready to chip in. The Grand Challenges Canada ready to chip in and provide funding for companies who are ready to get into this system, especially focused, very, very clearly focused on the overall good of the communities that are, disadvantaged, I would call it. I would call it the bottom of pyramid, but disadvantaged communities, because infrastructure doesn't exist, or the the doctors are not there, or you need telemedicine outfits out there. So um, yeah, I would say there is a lot of flurry on investments.
Yeah, and one of the things that I want to really tell the participants here is that the devices and the companies that will be registered in the registry, and there are also telemedicine solution providers that we have a registry for. We will try to create that ecosystem, and we will try to populate this information about these resources to them, which will help them as an additional. I mean, that's something that DH India will do so that we can serve this community better. Gopi, I have a question for you in the same regard. That you have large set of population which is on telemedicine. Would you be open to considering helping any device manufacturer to do a pilot using your system? Do you have a system which you can help them to do, or similar systems like yours?
Okay, let me also give start with a comment before I come to your question. I mean, the answer to your question is yes, but with certain conditions. So I'll come to those conditions. Increasingly, the public sector realizes, especially in the poorest states of India, the public sector realizes that it's not able to provide care on its own, and it is seeking help from outside the public sector, which is primarily from the private and NGO sector. Private and NGO are clubbed together. There's no differentiation there. To answer your question about devices, how it will be used, the public sector doesn't bother too much about the devices anymore. It is moving from what is called the process orientation to output orientation. The public sector defines the outputs. These are the services, and those services, if there is a treating doctor, doctor should have access to, say, blood pressure, or should have a stethoscope available. All these are duly certified without really getting into who the maker is, what those are. Okay. Instead, it just defines the outputs to be there, and the outputs will be paid for. We will pay you, say, 100 rupees, whatever, per consultation. So you'll have to tailor it accordingly. There are a couple of programs which are focused on the process, where the government says, these are the devices. You have a list of companies from where these devices could be procured. If you're a device maker, you'll have to go through the hoops, because initially we were making our own devices through a company in Bangalore, and you'll have to go through your field trials and tests, etc. It's enormously complicated, and it also prevents you from the upgradations that may happen. So be careful is what I'm saying. Currently, the government programs are being tailored that way, where the focus is on the outputs without really getting into it, which is an opportunity, but the devices to be deployed will have to be certified, understandably, because the government has to make sure it's good quality devices that are being used, but without really getting into the specifics of it. In terms
Sure, carry on.
In terms of using our platform, WHP's deployment, we'll absolutely welcome anyone who wants to try it out. But the only thing is, make sure that, see, ours is on the one side, the public sector side, there's nothing much we can do. We'll have to go by what the public sector does. In the private sector, there are huge opportunities available. In fact, I would even say, before there was a question earlier about how do I collaborate with the public sector to try out these devices, and which I gave that overview of it. It's not easy. Public sector is quite risk averse. So public sector feels much more comfortable if this work is done outside, it has demonstrated its efficacy and utility outside, then integrating it into the public sector is much more simple than again, I can understand, because these are folks who come for 2-3 years, and there are all kinds of oversight pressures on them. So it's easier if you can try it outside. So understand, organizations like us always need these devices, but engage with the organization first. You don't come and say, this is a device, please let me use it. No, first understand what deficiencies we have, what shortcomings we have, what are the gaps in our service delivery processes, and then fix a device accordingly. You don't develop something in a laboratory and say, please deploy it and help us, monetize it. It's going to be much more complicated. You come to us, let's have a discussion, and then we will say that or you visit in the field, and let's find out these are the gaps that can easily be addressed, go back to your lab and put that together, then it will work. Then there is an immediate kind of transition that can happen. So it'll have to be evolved in a collaborative way rather than a laboratory only way. And we are collaborating with a couple of, as it unfortunately only because we haven't had any exposure within India, but a couple of universities in the US whose students work because they have those projects. And so we have a constant interaction between us. And then the students work on specific projects that will fulfill a need for us. We would prefer it if it is not students, because students, they come for a short period, and once that term is over, they go away and the next batch comes. So we would prefer if it is a company which works on it. But after we have engaged in a discussion, discovered areas of common avenues, common interests, and you proceed from.
Yeah, thank you so much, Vijay and Gopi both. There is the big challenge that most of the device manufacturers, or at least the entrepreneurs who want to get into the space, comes from two things. One is, of course, as you rightly pointed out, the initial idea from where they get, the understanding of what they need to build. Normally, sometimes there are very small personal challenges, which is what drives them into making a device saying this can solve this problem, and assuming that the problem that they have faced during their care or the care of their near and dear ones is what needs to be solved for everybody else. That may not that may be just the part of the truth. So to understand the larger problem, it's better that at the ideation stage itself, there is an interaction with the users. And then, of course, the big problem is getting, areas for clinical trial, like what Avinash was mentioning, that to really try it on field. And I think there could be uh, some room here where we could help people get together and create a community where such interaction is possible. And Pramod, you said that you have a used case for Gopi.
Actually, uh, I think if I sit down with Mr. Gopi, I'd probably have a 3-hour discussion with him too, because
So you can
finally I'm getting to
right
speak to
now
a
you do it
person.
in 5 minutes, okay? You don't have to
Anyway, okay. So let me start with 3-4 points which I want to cover when I have Mr. Gopi's here. One is, unfortunately, Mr. Gopi, the dream of interoperability has been shot down. There was something known as the National Digital Health Blueprint, which actually would have covered those bases. But it was all finalized, it was all in place, it was very well architectured. We have examined it very carefully, and it would have been something that would have worked. It would have taken 3 to 5 years to have put in place, but it would have worked. Unfortunately, they've short-circuited it and gone a different architecture. So now it looks like we'll have to look at a bottom-up sort of an approach, and that is where I think having an organization like yours helping us get this going, because whatever it is, interoperability is needed. Maybe from even primary to secondary to tertiary. Now, first problem in this ecosystem of primary to secondary to tertiary, and for example, like the UP government now making it 10 years compulsory for the PG residents to be part of the public service. How much is this private practice going to take away from actual public health service provision? Now, the reason I say this is, anywhere you go where this is allowed, for example, in Tamil Nadu or even in Karnataka, you find these doctors literally, like you said, firstly, only 3 or 4 will come. Maybe about 20% will come attend any given day, and they will disappear by post lunchtime or maybe maximum by 4 o'clock, right? So the continuum of care is not from primary to secondary, tertiary. It is primary to private practice, and maybe back to primary, like that, right? Number one. Number two, the question of medications. It's a very serious problem, because I am very closely connected with the mission hospital ecosystem in these areas, and they have constantly said that the generic medicines 30 to 35% are spurious. Now, these 2 points I would like to ask you your opinion and how you think we can solve this, because it comes to the crux that you need a primary care like doctor available to begin with, and not spend time in private practice and so on.
This is there is a lovely saying in Punjabi which I can't reproduce in Punjabi, which is like the the lady of the house forgot to put a lid on the milk, the container containing milk, and the wily, villainous cat came and drank the milk. Cat will drink the milk. If you have a system in which the doctors can goof off after half an hour and go and practice in private and make more money, they will do it. We will have to set up a system which, if you are paying a salary to the doctors, it is the manager's responsibility to extract the appropriate amount of work from the doctor. What systems you develop to do that will determine how efficient the system is. To um, look at it from a moral standpoint, saying that the doctors are goofing off, you have to assume, the basic assumption will be, if given a chance, they will goof off and do things which you don't want them to do. How do you get them to do things which you want them to do is the question of how the management structure is to be built. So, so I'm just shifting the onus on the managers of the system rather than on the other constituents, because the other constituents will behave in a way which is beneficial to them, and if they think they can do something away from the terms of reference that they have been given and get away with it, they will do that. It is a natural tendency, especially when the work is happening beyond your line of sight. Somewhere in the interior area, there's a PHC and the doctor is expected to work there, is not doing it. We will have to figure out mechanisms by which this is controlled rather than expect the doctor to kind of discover God and do work accordingly. That's not going to happen. The second one is medicine. There are conflicting reports available with medicines. There was one Home Ministry study about 2 years ago, which found 7% of the medicines to be spurious. So this keeps changing, but there is definitely an overall improvement in the medicine, in the availability of formal providers providing medicines. The major reason why there are these spurious medicines is, again, because your drug inspector system is completely broken. Probably the most corrupt part of the health situation, health scenario in this country is the drug inspector, who allows all kinds of things. Most of the pharmacies are not registered, and a lot of medicines that come there are from uncertain origins. So though, again, it's a management issue. At the end of it, we will have to figure out a way of knowing the metrics that are available that tell you whether the medicine is of the right kind or not. Similarly, whether the people who are deployed there, whether they report for duty and what they do. Telemedicine, therefore, that's what I'm saying. I don't want to define telemedicine just as a connect between a patient and a doctor. It can be much more than that. It can be a monitoring tool, so that you can get people to I would say, instead of telemedicine, it's more of a digitization of the healthcare delivery system into which telemedicine is incorporated for a certain function. So that is in fact your ecosystem, and that's how it'll have to play out.
Yeah, so in fact, that is the crux of it, I think, because telemedicine on its own, without this having this, for example, the manufacture to dispensing mechanism for medicines, it all working together, is how probably the solution will come about, right? Is that what your take would be?
That's exactly what should happen in this. When I remember the first time I lived in the US for some years, and the first time I went to get eye drops, I didn't have a prescription, and I had to pay $35 for a stupid eye drop, which used to be, Locula used to be some 7 rupees or 8 rupees those days in India. And the reason, because I didn't have a prescription. It is a well-regulated system, well-controlled system, where that's how civilized health systems function. In our case, it's free for all. There are too many vested interests. The pharmaceutical companies are a big lobby, and understandably, they would be big lobby if they can be a lobby and make huge amounts of money. Of course, they will do it. It is for us to figure out what the terms of engagement will be, and then have a mechanism by which those terms are enforced. We don't have it. We want to take shortcuts and look at it from a moral kind of prism, saying, oh, people are doing all these wrong things. People will do wrong things if it benefits them. So we'll have to figure out a mechanism by which they are prevented. That's how do you achieve that, is what we'll have to figure out.
Thanks a lot. Thank you so much.
Jyoti has a question. Jyoti, you can unmute yourself, or shall I unmute you?
And if you could also say who you are so that I can understand the context which you're saying it.
Yeah.
Yeah. Good evening, sir.
Good evening.
Yeah. Sir, I'm Jyoti Junagal Karlupia and I'm doing my PhD from IIT Roorkee.
Yeah, Jyoti.
Yes. So, sir, my question is that I'm doing my thesis, this PhD on design thinking.
Okay.
And I want to ask a question that how design thinking approach can help leaders for achieving sustainable development in healthcare system.
Hmm. Oh, Vijay. Vijay भाग गया.
Yeah, nahi,
No, let's put our heads together.
No, the thinking part of it, Jyoti, is basically uh, in design thinking, the most important part of designing at the center of the design is your consumer or your user, right? And that is where you design an equipment or a process or whatever it is that you want to offer, keeping the design at the center of it. And that is where Gopi is actually located. He is the person who is having the need, undergoing the pain points. And so therefore, one of the most important parts that I would recommend to startup companies is to do at a very early stage of your design process, which they call design thinking these days, is the customer interviews and the insights that you will get from your customers. So I would say that this is something that is there. Of course, I mean, design thinking brings in all the other elements that are part of it, but the central to the whole thing is your ability to sit with folks like Gopi and practitioners like that and say, let me understand your problem in more detail. And that is where I will design the whole thing around that particular problem. So the thing is that the problem is there today, it may disappear tomorrow, but the fact is that when you design something, you design it for the fact that you're addressing a problem that is going to be, contributing to solving that problem. Did I answer your question?
Let me add to it. That's I just want to add to it.
Yeah.
It's because it's an interesting dimension that Vijay has given as usual. Um, let me stray away from healthcare and understand how designs will have to be made if you have to have programs that will operate on a large scale. In a country like India, you'll have to think large scale, otherwise it's quite meaningless. Let's take demonetization, okay? Or let's even take the GST issues that are there. Everything was thought through, everything was put together. But the reason why it created so much of complication is not because of what happened in areas where the infrastructure was pretty decent. You did not anticipate what people on the other side of the table would do to what you want to do. If you don't have an understanding of it, what is going to be the blowback? What are going to be the loopholes or the avenues that your design has, which will be exploited by the other party? Then your design will collapse or it'll be weakened. So in design thinking, I think the primary need, um, uh, especially when you're trying to reach people living in low infrastructure area. Infrastructure is a huge conditioning agent. Infrastructure conditions human behavior. If it's not. There are some rules that come with infrastructure that gives you an ability to design certain things because you know that in a well infrastructured area these are the rules that will apply, and therefore let me design accordingly. Your problem comes when you want to go beyond the well infrastructured areas to communities living in those weak areas where things happen on their own. Things really don't have a set of norms because it's very situational or incidental, and you'll have to have a deep understanding of it. So spending time with them to do some kind of qualitative research to understand the mindset, because those people will apply their own logic to what you are offering. And that logic it has a potential to screw up what you want to do. Exactly what happened with your GST, exactly what happened with demonetization. By way of what the government wanted to do, I would agree with the demonetization, tried to make the economy more organized. Okay. And GST also wanted to create a market. But the problem came, but the people who were affected by it, they had their own pressures inflicted on the system, and that changed the game, and it created. So you'll have to do your war gaming and understand what is going to be the result of others on the plan you have. And that is going to be the critical factor in design thinking. If you don't factor that in, okay, all these large-scale programs work on what is called an assembly line principle. Assembly line principle is that the slowest moving part of the assembly line, the slowest link will determine the speed of your chain. Okay, and if there is one link has become dysfunctional, over a period of time, the entire assembly line will become dysfunctional. So you will have to, that is true of even digitization. You will have to understand the role of each link and understand how efficiency can be achieved with that link. And your design, therefore, by and large, concentrate on areas you don't know, the people who will be affected, and what they will do to what you want to do, and how will it affect your plan is going to be the most critical part of the design thinking, especially when it comes to operating or trying to reach services to communities which are living in unorganized areas like weak infrastructure, low literacy, high poverty, etc. Sorry, long answer.
Thank you, sir. Thank you.
Jyoti, one more thing. Are you familiar with quality function deployment also?
Quality function, no, sir, not
Okay, I
currently.
would suggest you can Google it. Suggest that was introduced by Toyota and people who worked in the automobile engineering in Japan.
Deming and
yeah, basically also sort of talks about how a product is designed and what are the inputs that go into a product and what is good to have and what is essential to have. All those design functions are discussed. Have a look at that. I think I'm still a practitioner of QFD, not much of design thinking, because I think design thinking is more nebulous than quality function. It's much more rigorous in that process. So yeah, Dr. Umar, don't smile. It's not because it's Japanese origin, but the fact is that
I don't think others probably don't get the joke, Vijay. What his origin?
well, yeah.
I think
So
the others who've seen it, probably they can see that there is some Japanese genes in him. So you can,
well,
that's the joke here.
the whole thing is quality function deployment has been through a lot more case applications than the newfangled Stanford design thinking concepts. So, but then they're all common sense trying to put together things together, and I think the detailing is great. So have a look at it, Jyoti.
Yes, sir. Okay. Thank you so much, sir. Thank you.
You're welcome.
So there is one more question, I think, is related to the same informal sector that we were talking about in rural areas. That is there a role that the devices can play? That is, if the devices are with the informal sector workers and they, let's say, gather the data and then it is provided to the care providers at the other end, will that bridge a certain gap? Will that be a use? Is that something that is a workable idea?
If you, the only difference between an informal provider and a formal provider in terms of the competency, and this is true not only of the informal provider, this is true of frontline workers, including the ASHAs and the ANMs, is that they are very, very comfortable with numbers. One of the reasons why mobile phones have exploded across the developing world is because it's all to do with numbers. Even people who are barely literate are able to do a very good job with mobile phones because it's all numbers. But when it comes to text, anytime you want to enter text, they go to pieces. One of the reasons why a lot of government programs don't do very well is because at the front end, you expect the A&M or the ASHA to enter text. They are not able to do it. Even if it is English, bad enough because they are not familiar with the language. If it is Hindi, it is equally complicated because English alphabet is not really suitable for entry like that, because it's got your matras and other things there. Okay.
Yeah, but it's like, your vital parameters, SpO2, blood pressure
Yeah,
monitoring.
so if you can get them to enter data number, and this is we reached this conclusion the hard way, because earlier we were giving them all the responsibility. Later, when we realized they're having problems with the text, we have a call center. The moment any text is to be entered, the person from the interior area calls the call center, just reads out the text, and the call center enters it and immediately pushes it. And it is done so efficiently. In Rajasthan, a UN organization distributed 10,000 tablets to the frontline workers, okay? And where the responsibility is collecting data, which means both numbers and text, it just collapsed for the simple reason that they had trouble entering text. So anything, otherwise there is not much of a problem at the front end. Whatever devices work at the back end, whatever devices work in the cities, in a formal hospital, formal facility, would by and large work in rural areas. So you tailor it accordingly if there is anything you can do from that point of view.
Vamshi has another question. Vamshi, I'm going to unmute you. You can ask yourself. Yep, go ahead.
Hello, sir.
Hi, Vamshi.
Hi, sir. Is there any other sectors that require immediate assistance, like healthcare analytics, apart from telemedicine?
Analytics is a completely unexplored, or rather, it's a kind of very minimally explored area, and it's a huge potential for analytics, because we have not, we Indians, especially in the healthcare field, we haven't mastered the art of using data to take good quality decisions, and it's a huge area. This is, in fact, enormous potential. Plus, a country with such vast population also provides so much of data. I'm sure Vijay will have more specific inputs to provide on this. It's a huge area. A lot of decisions.
Completely agree, sir. Actually, I'm a AI enthusiast with a machine learning technological background. I was trying to make a mask that can detect the respiratory perception from the patients who wore them, and provide analytics based on what are their respiratory products, what is the type of respiration they are taking, how many times they are coughing. All these analytics can be used in federated learning apart from mobile case studies. So it can be combined together to form a machine learning model, and can artificially detect what the patient's respiratory detection can be by making predictions using machine learning models.
Fascinating stuff. Fascinating. Yeah.
Thank you, sir. I'm currently working on this project.
Yeah.
So Vamshi, I think it makes sense for you to connect with the clinical community as well, and to see what is it. And I hope you have some, discussions with the clinical community to see what is the kind of output they would want from your analytics, and what is meaningful decisions that they would be looking at. And I'm going to invite Vijay also to give a comment.
And how will it be deployed? How will it be deployed? Will it be deployed at a facility? Will it be individual based, etc.? Just think through that, because that would be very,
Think
very
through
useful.
that, and we'll be also happy to connect you with clinicians if you really want any inputs on that.
Thank you, ma'am.
Look forward to helping on that. Vijay,
Thank you very much.
do you have any comment on this?
Vamshi, I think Dr. Omar said it. This needs a discussion one-to-one offline, but you know where to go. So
Thank you, sir.
that's important.
You
When coming to
feel free to connect with us, okay? And since your product is, if you're thinking of this as an idea that you have in mind, it really requires a very solid, planning, and like what both Vijay and Gopi have also emphasized, and you've understood that it's very essential that your basis, or your base of your thinking and what your idea is, your concept is very clear, so that your output is that much more better and more useful. So, more groundwork required, do it, no problem. We'll be happy to help, and feel free to connect with us, and we'll put our email IDs at the bottom. I think you might have. Have you registered for the awards?
I did, ma'am.
Okay,
I
you
did.
did. So that means you are connected with us. We'll also get back to you on this. Okay, we'll help you to support whichever way you want. Okay.
Thank you, ma'am. I look forward to it.
Yeah.
And
So
coming to deployment model, I was more focused on federated learning. I think you are more uh, sophisticated, and also it is diverse, ma'am. When it comes to mobile technologies, everyone is using a mobile phone nowadays. So when we use a federated learning model for the deployment, every mobile phone holder can use this machine learning model locally without using to connect it to the cloud sources. So for the deployment model, I'm preferring a federated learning that is introduced by the Google community.
So, Vamshi, just a quick input was probably in continuation with Jyoti's PhD, is that I think you need to move the focus away from the tools such as federated learning, machine learning, and all those things to the actual clinical performance or the clinical utility of your device. What does it do? Does it diagnose a disease? Does it help in providing a therapy to the patient, or does it help the patient in being able to comply with medication, or for that matter comply with certain advices that he has got? That is where I think you need to basically try to focus on, and
yeah,
have
or
all
is it
these.
for the clinician, or is it for the
Yes,
clinician
for
to
the
take?
clinician to be
Yeah.
able to make a decision.
Mm.
What do I do? Do I operate now? Do I not operate now? That kind of decision. Do I give him this
Yes, sir.
steroid shot or not? That sort of a thing. So I think you need to bring that central focus down to the utility of the product, and that's what all the discussion about design centered thinking um, is about. So yeah, feel free to catch up anytime, and we
Yeah,
can
I
chat
completely
about
agree, sir. It has many uses, but I currently focused on detecting COVID-19 symptoms
it.
by integrating it to the face mask.
Vamshi,
Sure.
COVID-19 is a disease which is soon getting under control. So don't put all your eggs in one disease basket. Make it a generic uh,
Yeah. COVID
product,
20. Make it for
because
COVID
see,
20.
COVID is just one of the
Yes,
millions of diseases that we are treating, isn't it? So
I
it's just
completely
that,
agree, ma'am.
yeah. So it is just
In
that
fact, in
every
fact,
5 or 10,
TB,
yeah,
TB, yeah, TB.
yeah, yeah.
huge
That's a great
traction for.
advice, sir.
Yeah, yeah. Go to, yeah, and we need to address diseases which are going to be. I mean, they're far more of a problem. So diseases like COVID, every 5 or 6 years, you will be hit by some kind of a disease which will have uh, some endemicity. Whether it was the SARS viruses earlier, H1N1, and we've had every 5 to 6 years you're coming up across a disease, and it will have a magnitude which depending on how easily spread it is and how far it spreads, and then soon it will be under control. But we have larger issues of diseases in mankind which have been there for years and which are very difficult to tackle. I think we need to start looking at it. And also there could be some generic products. I mean, it could be something which handles respiratory diseases, the whole plethora. I mean, we could have a discussion with some pulmonologists, help you to look at some of that. And we need to look at those kind of things. Yeah, so yeah, so that's
Duly
something.
noted, ma'am. I will
Yeah,
take that advice.
yeah, and yeah, we'll be very, very happy to connect with you, and you can connect offline with us. All right.
Sure, ma'am. I look forward to that. Thank you.
And so I don't have any other question here. Is there any closing comments from Gopi?
No, this is so nice to see such interest, and I'm sure telemedicine is, as someone mentioned in one of the comments, it has come to stay. How we utilize it, again, let's steer away from telemedicine into the larger, how do we exploit the digital opportunities that are available, and look at healthcare as a whole, into which once you have the master plan, and that's something which we'll have to engage with the public sector, especially the government, to put that together. If there is a national consensus, then it will become easier so that people don't run in different directions. That's a focused way of doing it. So those are the next steps forward. Consider the entire range of activities that will have to take place to have a comprehensive, holistic system of service delivery, right from simple illnesses to extremely complicated ones, and the support services that will have to be built in, whether it's a supply chain, whether the analytics that will have to be brought in there, whether there are the managerial tools that will have to be employed to ensure that the constituents behave in an anticipated way. If there is a deviation, the deviation is caught. If there is an outbreak, if the populations can be clustered and we find there are high incidence of a particular morbidity in one area, how is that alerted? How do we define an outbreak? How do you define a pandemic and an endemic? Because when we're trying to do that, when we are building the system, I got in touch with CDC to find out what are the difference between an outbreak and an endemic. What is the number? Because at the end of it, everything will be numbered. And they didn't have an answer. So we now have our own kind of definition of it. All these are areas which will emerge as we get to realize more and more opportunities and more need of what is required. So this has been an extremely useful, interesting kind of platform for me. So thank you so much for inviting me.
So this outbreak and endemic and pandemic thing, it could have been classified as numbers when we were not such a small connected world. Now that the world has become very, very small and it has shrunk to,
No, what I mean by the number is that suppose say there is a village of 1,000. Okay,
yeah.
If there are what is the difference between an outbreak and an endemic pandemic or anything is only is defined by the scale of it. So
Right.
it may be 3 per thousand in a village may be an outbreak, but 3 per thousand in a district may be a pandemic or an epidemic.
Yeah.
Or an epidemic. So those definitions will have to come. They haven't come yet.
Yeah, and probably whatever little was there, they need to be defined and probably
redefined. It'll have to be reworked. We'll have to revisit all of them. Yes, correct.
Yeah,
so those are because these will have to be integrated into the system, so that in a village, if there is a fourth patient who reports with a particular morbidity, immediately the system alerts you saying there is an outbreak in that village. Please go and attend to it. This will become part of the analytics. The system will do the deviation and give you the
and it will also differ from the disease. Your first Japanese encephalitis is an epidemic for you.
Or the first case of polio. First case of polio is the information go right up to the minister.
Yeah, and whereas you could have your 20th case of viral hepatitis, you still are not panicking so much.
Correct. So we have the numbers. In fact, we built it. We have different numbers for different morbidities. We already have it, and integrated with Google Maps and coordinates, the physical coordinates, etc. All those things are they are the way forward.
Yeah. Vijay, closing comments from you?
No, I'm not on mute. Yeah, I guess I thoroughly enjoyed this, and I just can't help stop thinking about things in say 2025, 2026, how it's going to look like, and these learnings are going to be only reinforcing the process by which we build the telemedicine infrastructure of the future. One of the things that I would like to, sort of spend time or probably, split, knowledge with is with the infrastructure development that needs to go with it, because it always happens that, great thoughts are there, great initiatives are there, but ultimately the infrastructure lets you down in some way. In many ways, a lot of these web conferencing things, very great futuristic way of doing meetings, but suddenly the internet doesn't work for you, and you're back to square one. So, and I'm not talking about villages. I'm talking about, even in cities. So I had a scheduled conference, web conference with the Indian Institute of Science, and it didn't happen because they had a breakdown, right? So, um, so I would like to dream about, and that's predominantly the kind of job I do, is I like to dream about what could be the best way forward. And maybe some of these learnings already have given an idea of where exactly we're going, but I loved having uh, Gopi sit down and give us like a fireside chat about, his experiences. And I'm sure a lot of participants here would also have, gained these insights without actually uh, having to undergo most of it themselves, but would be great learnings there. So thank you very much for having this opportunity of joining this chat, and then I would like to also thank on behalf of some of the participants who seem to be tremendously excited about what are the possibilities that come up with from these discussions. Uh, so have a great evening.
And it's
Yeah,
interesting to know most of them have stayed on because
yeah.
whoever started with the numbers have more or less. So it's nice to know so much of interest.
Right.
Well,
Yeah, thank
yeah,
you.
that's the future of our country that is actually sitting here. So it's a good
That's good to know.
opportunity for us. Yeah,
These are the
And
opportunity.
dreaming scientists. Most of them
uh,
are the
it's
dreaming scientists that
reassuring.
are
It's,
sitting here.
it's really reassuring to know this. So
Yeah,
thank you.
so the
It is the
baton.
dreaming scientists that makes the changes. And
Yes,
I'm happy that many of them who are here are that group of,
yes.
yeah. So, yeah, so I really thank both of you, Vijay and Gopi, and all the
You're welcome.
participants here. And, we will continue, we've been doing these webinars and we will be continuing to do this 2 weekly webinars. But the next, I think, is 2nd of January. And I think, I don't know, most of the people will have a hangover after the 1st of Jan. So probably we'll shift it to 8th of January. Okay,
If they
something
can get
like
the
that.
boost, everything is shut off.
No, but people stock it up at home. At least that's what I do.
I
I
see.
stock it up well before time so that
Not
I don't have to depend on the shops on the last day. So,
AFC products know the game.
yes, yes, you guys. Anyway, so that's another learning for all of you today. Stock your bar up well before the New Year celebration. Okay, so that's one. But what I really want to do, and I want to tell everybody that we use telemedicine or telemedicine ecosystem discussions as a prop to larger discussions around digital health. And if we really see, I mean, when we talked about continuity of care and, how will the management and the managerial systems will work, we all know that the best person to take control of their own health is the individual themselves. So when we get into the stage of personalized health records, then you'll find that whether the government doctor sits in his public healthcare space in a PHC or in his private clinic, the patient will demand that the healthcare record be updated, and those things will happen. But that's a stage that we all have to walk to. We all have to build our systems to reach that space, and that's the reason why we all are discussing. And what we will do is probably going forward in January, that is either in on 8th of Jan or perhaps in the end of January sometime, we will be bringing all the applicants of the device registry for healthcare telehealth ecosystem and the telemedicine solution providers together for a discussion like this. And hopefully, and we will probably have discussions between the participants so that it will not be a structured talk. There might be 4 or 5 people who will give a 2-minute introduction, and I'd see whether that kind of interaction can happen so that people who are working on the ground will talk to each other. Okay, because all of you, I'm sure, listen to a lot of webinars from big speakers and all of that. But we want to try and actually build a community that's working on ground and connected in the real world. and not really sitting in the cloud. So that's something that we want to do. And that would be our endeavor, because what we really want to do is create working systems on ground and help you all to, with the inputs and the resources, to see whether, we can all work together to create that space, create that ecosystem that we are talking about, and have good healthcare for all of us and all our patients. So if there are no more questions, I'm going to thank everybody and wish everybody a Merry Christmas and a
And a
Happy New
happy.
Year and a good boozing week from 25th to the 1st. And we will meet on the
Oh,
8th of
yes.
January. So that's we will do. And
Yeah.
please feel free to ask questions, connect with us offline, and make the sessions very interactive, because the more questions there are, the more we get to learn as well. So thank you for such learning opportunities for all of us. Thank you, everyone.